Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Good morning, everyone. Lovely to see you all. It's great to be here. So welcome to CATHIP's Health Hour today. My name is Dr. Vanessa Rapier, and I'm your host. And always, we've got a really packed time with really fantastic speakers today, who are introduced in just a second. But just to bring it all together in terms of why we're here. Again, I always say that we never take it lightly that you join us on a Saturday morning to share and learn and just benefit from each other's experiences. And so, as has been said in the video, you know, CATHIP is a collaborative, and it's educative, and it's empowering health literacy so that we can make sure that people within our community have the information to take control of their health and also to support others. And we do it in a collaboration, and it's made up of a number of partners who I just want to acknowledge right now. So we have the Caribbean and African Health Network. We have the Black Health Initiative from Leeds. We have the Royal Assembly of the Redeemed Christian Church of God in Sheffield. We have RAFA International Development Agency, which is across the UK. We have the Croydon BME Forum, and also the Enfield Caribbean Association. So really fantastic organizations which have come together to give you, to help educate and support and give you the support that you need. So without further ado, we've got a very special topic today, which is about anesthesia. And it's a topic that I don't think we talk about enough, and we only really know about it when we are going for an operation or a procedure. We think about it then. So we're really honored to have two fantastic doctors with us today who are going to share their experiences and just to inform us further. So I'm going to introduce Dr. Regina Graham and Dr. Chris Williams. And so Dr. Williams and Dr. Graham, I'm just going to hand over to you. Thank you so much for coming on today.
Morning, everyone.
Morning.
It's really great to be here. My name is Dr. Regina Graham.
And I'm Chris Williams.
And we are both doctors who work in anesthesia and intensive care. We currently work in Nottingham. So it's lovely to be here. We're going to kickstart our presentation and we'll do questions and answers at the end.
Perfect. Well, whilst you share your screen, just going to remind everyone that this is a platform for you. So feel free to ask any questions that you would like to any questions that you would like to at the end. But as you go along, you can put your questions in the chat. We'll be collating them. And then also feel free at the end to put up your hand and ask any questions. This is all for you. So that's great. So just going to hand over to you guys again.
All right, thank you so much. So the focus of the talk today, or the presentation, is really to give a better understanding as to the role of the anaesthetist and what having an anesthetic entails. In my personal experience, I found that, at least back home in Jamaica, many persons really didn't have an idea as to the role of an anaesthetist, or, you know, they thought that everything had to do with the surgeon. And so we just like to shed a bit more light as to what we do. All right. Right. So we'll be taking a look at what is anesthetics, who is an anesthetist, why that should matter to you as a potential patient, why would you need an anesthetic, what are the types of anesthesia that you could have done, what might you have to do to prepare to have an anesthetic, because we do recognize that it's a doctor and patient relationship and patient involvement is key. What exactly happens when you're receiving an anesthetic? What are the risks entailed for having an anesthetic? What to expect after you've been given an anesthetic? And then we'll have a question and answer period. Right? So what is anesthetics? Anesthetics is a practice of delivering anesthesia. All right. So that leads to the next question: what is anesthesia? Anesthesia simply means loss of sensation. And for a more formal definition, it's the loss of the ability to feel pain caused by the administration of a drug or by other medical interventions. And in its most basic form, its aim is to lessen or prevent pain or discomfort during a medical operation or procedure. An anesthetist is a medical professional who has received formal training in delivering anesthesia. That doesn't mean that all anesthetists are physicians or doctors by training. You do have some anesthetists that are nurses by training, and you have some persons who are anesthetic practitioners who don't necessarily have a massive medical background or have been specifically trained in how to deliver anesthesia and do so safely. Okay. In general, anesthetists have advanced knowledge of how the body works, and we manipulate the body's function to achieve the effects that we require. And we'll get a bit further into that as we go along in the presentation. We don't just simply put people to sleep. The anesthetist has many roles in the hospital setting and even outside of the hospital. We generally staff critical care services or intensive care services. Many of us work with ambulance services as well. We work with, for instance, like the helicopter service or the road ambulance team. And we also assist with resuscitation of patients in various parts of the hospital. So our major responsibilities, our main responsibilities as anesthetists include assessing fitness of a patient for an operation or procedure. We'll get more in depth in that as we go along in the presentation. We'll determine which anesthetic approach would be best for a given procedure in conjunction with you, the patient. It's always a discussion. It's always something that we would like your input about. And so we definitely will involve you in that part of things when it comes to that. We'll come up with a plan to control pain or discomfort after your procedure and during. And we'll carefully monitor and look after you in the operating room during a procedure. As we proceed, you will see how significant the role of an anesthetist is, and the things that we will need to look out for, because we're basically taking care of you to make sure that the surgery can go on in a safe manner. Okay. And we also look after you immediately after a procedure in the recovery area, or if needs be in the intensive care unit. So why would you need an anesthetic, right? I'm sure we've all heard of surgeries, but there are many medical procedures that do include surgeries that can be quite painful or anxiety-inducing. We have manipulations of fractures or dislocated joints. We have some imaging or diagnostic procedures that can be quite uncomfortable as well. And so the delivery of an anesthetic allows us as patients to tolerate procedures which would be otherwise at least uncomfortable, up to the point of being excruciating or unbearably painful. All right. And anesthetics from a chemical background came to life from the discovery of nitrous oxide and ether. in the early or mid 1800s, when persons realized that by huffing or inhaling nitrous oxide or ether, that they were less sensitive to pain or painful stimuli. So what are the types of anesthesia that you could have done? What we tend to think most about when we consider anesthetics or having an anesthetic done is a general anesthetic, which is where patients are put to sleep, okay? It involves being given a combination of agents which lead to a decreased state of consciousness for the patient. It may include different types of medications such as sedatives or hypnotics, which are simply medications that make you drift off to sleep. Analgesics, which are medications that help to reduce or prevent pain. And it may entail paralytics or relaxants. These are more advanced drugs that won't be used in every circumstance, but may be necessary to facilitate certain types of surgery. And basically what that does is it takes away your ability to move. Now that sounds scary, but as anesthetists, we're trained in how to deal with these kinds of, how to administer these drugs and how to deal with these situations. And we will get a bit further into it as we go along. And a general anesthetic, as I said, which is one that puts you to sleep, is usually given for surgeries involving the midline. So the patient's head, face, neck, thorax, abdomen, because it allows us a greater degree of control of the area in question for the procedure that needs to be done. As I said, sometimes we give medication that takes away your ability to move, which also takes away your ability to breathe. Now, not to be startled, that sounds quite scary, but if it is that you do require any type of medication, and even the medications that we use to put you off to sleep and to take away your pain sometimes can cause a reduction in your breathing or cause you to stop breathing, we will take over your breathing for you, okay? So when you're watching, you know, those medical shows and someone says, we need to intubate, and they put this tube in the mouth, that's exactly what we're talking about. And we may connect you to a ventilator, which is a breathing machine, or we may use other methods to make sure that you continue to breathe and we continue to provide enough oxygen for you to be safe, okay? Apart from that, we may also give other medications with a view to preventing some of the more common complications or adverse reactions to an anesthetic, such as anti-sickness drugs. We often give antibiotics as part of the surgical plan to try and prevent infections. And as I said, we'll give some strong painkillers, and we try to make sure that you're comfortable throughout the procedure and afterwards. Right. Another type of anesthetic that we deliver is called a neuraxial anesthetic. The neuraxial sounds like a bit of a, you know, highfalutin term, but it's quite simple. Neuro from nervous tissue, and axial meaning in the center of the body. And what we're really looking at for a neuraxial technique is we are giving medication around the spinal cord. The spinal cord is the main conduit of nerves that goes from the brain to the rest of the body, and it connects the nerves from the rest of the body to the brain. And that is how we are able to appreciate sensations. So pain, hot and cold, pressure, touch, etc. So by delivering this medication close to around the spinal cord, depending on the type, what it does is that it inactivates those painful signals that are coming from the nerves and going up into the spinal cord and going to the brain, so that the brain no longer perceives what we're doing, which might be a cut, a stick, etc. The brain no longer perceives this as being painful. So it makes it a lot more comfortable and a lot more tolerable for you, okay? These techniques, they can be utilized as a sole method of anesthesia. For instance, if you're having, you know, an operation done on the hip, on the knee, on the foot, etc., then we could just give you a neuraxial technique, such as a spinal or an epidural, and you may not need anything else. Just this by itself may, you know, take the pain away and make you so comfortable that you're able to tolerate that procedure without any further need for any other medication. However, we do sometimes combine the techniques. If it's a pretty extensive operation, we may give a neuraxial anesthetic in addition to a general anesthetic. And this is because we found that the pain control is so good using a neuraxial technique that it reduces the amount of medication that we need to give you during a general. and also because it's so good for pain control after the fact. So when you've already woken up, when you're, back and breathing again and starting to become more aware, it's a very good method to control your pain so that you're comfortable after the procedure. This is just an image, looking at it now, it's probably a bit grainy, of a neuraxial technique. We can see that, I'm not seeing my mouse here, but what you're basically looking at is the patient's back. That syringe has some medication in it, which we'll be administering into that needle, which is going into the patient's back currently. It sounds quite uncomfortable, but we are quite aware that it can be distressing. And so we make sure that we give a lot of numbing medication. We also coach the patients through the procedure to let them know exactly what they'll expect and to manage their expectations accordingly. And it's usually tolerated quite well. So, as I said, as the sole method of anesthetics, they're usually employed for surgeries on the lower half of the body. So for the lower abdomen, for the pelvis, specifically for ladies who are having cesarean sections to deliver their babies. It's a very popular method of anesthesia. You'll hear them speak about epidurals and spinals, and also lower limbs. So orthopedic procedures, broken bones, knee and hip replacements, ankle fractures, things like that. And the two types that we use are the spinal or epidural. We won't get too much into what separates the two because they're quite similar. But the choice for this will depend on what procedure is to be done and also the evaluation of what may be required during or after surgery. Right? A regional anesthetic or a block is a technique where we inject medication around a group of nerves or around a specific nerve. And what it does is that it blocks the impulses of pain specifically from going up those nerves and being perceived by the brain. So similar to a neuraxial technique, but not done around the spinal cord. It's done around a group of nerves. So we may do this again if you're having surgery, for instance, on your arm. We may block the nerves that run going down to the arm at around the armpit level, and you shouldn't feel any pain in the arm. Similarly, we can block the nerves that go down to the leg. If you're having a procedure on the leg, we can do it for the fingers as well, for the toes, etc. And a local anesthetic is where medication is injected to a specific area onto which a procedure will be done. And a good example of this is when you're having stitches, for example, you've got a significant cut. We need to close it up with some stitches. So usually we'll give you a bit of medication or numbing agent around the area. That's a local anesthetic. All right. There's also topical anesthesia, which is where we will usually spray or apply some medication directly to the surface of the skin, or sometimes even other areas inside the body, so that you don't perceive the sensation and it doesn't cause you as much discomfort. All right. So I'll turn over to Dr. Regina, who will take you through the rest of the presentation.
Okay, so having heard all of the things or all the variety of ways with which we can handle your pain or blunt the perception of pain, what do you need to do to prepare to receive this anesthetic? So before your planned operation, the surgeon is going to have a conversation with you where they're going to explain the operation that you're having, why you need to have it. They're meant to go through the risks and the complications and what your stay will look like afterwards. Because some operations are quite simple and you can go home afterwards, whereas some are a bit more complex and will require you to stay in hospital. So you'll have a chat with your surgeon about your operation and what exactly that will entail. Once you come to an agreement, then they will send you off to get evaluations to make sure that it's safe to proceed with the surgery. And then that's where your anesthetist will come in. A part of your evaluation process will involve doing a preoperative assessment by your anesthetist, and then we'll go through a list of things, which I'll go through shortly, to deem how appropriate and safe it is. And this is how we'll then come up with the anesthetic plan and pick one of the anesthetic methods that were mentioned before, choose the one that's more appropriate to handle your operation, including what you are comfortable to handle as well. So what will this workup look like? So it's really important that we have an idea of your medical history. So we need to know if you have any illnesses, and by illnesses, I mean, do you have hypertension? Do you have diabetes? Do you have any heart disease, any kidney disease? Because as was mentioned before, as anesthetists, we understand how the body works and we use various drugs to manipulate those functions. And so when you have illnesses, it adjusts the way the body responds to certain things and your ability to cope with stress, because surgery is a stressful process on the body. And so by having an idea of any illnesses that you may have, it allows us to have a better idea of risks and help to prepare you so that it's safe to deliver the anesthetic. It's really important that we know if you have any allergies. Commonly, people are allergic to some antibiotics, and as mentioned before, antibiotics will often be given during surgery or even in your recovery period. And so it's really important that we know if you have any allergies so that we can tailor the medications that we give you to prevent any adverse reactions. It's really also important to note any prior surgical procedures that you have. Sometimes this can give us an idea of just your general state. So for example, sometimes people have heart attacks and they have stents put into the arteries of the heart. That gives us an idea of your overall health. But more importantly, if you've had an operation before, it's likely you've also had an anesthetic before. And this gives us an idea of your anesthetic history. So if you've had complications with previous surgeries, then we have an idea, and then we can use that to tailor any future anesthetic plans, because the priority, as we've mentioned, is your safety. It's also important for us to know what medications you're on. So some medications interact adversely together. And so it's really important that we know what you're on before so that we can, again, tailor what we give you. It's also important because there's some medications that are not appropriate to continue during surgery. So some diabetics, there's some class of medications that are used to treat diabetes that we might have to stop. Sometimes people are on blood thinners, and if you're on a blood thinner and you have an operation, as you can imagine, you're being cut, it increases your likelihood to bleed and have complications after the operation. So there's some medications that are not safe to give before an anesthetic, or you may be asked to stop. So it's really important that even if you don't remember the medications that you're on, if you can at least bring the prescription or just bring the medications themselves, that way we can have an idea and guide you appropriately, not only in, again, what you need to not have before your operation, but help us to help you in terms of what we give you during your stay with us. It's also, sometimes we might also ask you about the anesthetic history of your family, because there's some conditions, some uncommon complications of anesthetics that happen, and they can be familial. And so it's really important that even if you've not had this complication before, somebody in your family may have, and if we know that, we can plan accordingly. Another thing that we assess is your physical fitness. So I mentioned before how sometimes certain illnesses can affect your overall health. So we have an idea of, the illnesses that you have and how severe they are and how you're being managed. I'll give you an example. People who may have heart failure and the heart is not able to cope with certain situations. So with exercise, you might feel tired, you might have chest pain, you might have difficulty breathing or swelling of the ankles. These are the things that we look for in our assessment, because it might require further tests. Maybe we need to do a little echo of the heart to see how the heart is functioning, because as I mentioned, surgery is a stressful procedure. And so if you have any conditions that might worsen when exposed to stress, it's good for us to know first, and we test it in a safe way, in a safe environment and situation, so that we can have an idea of how you will react to a stressful situation. And therefore, we can try to optimize you before if we feel as if you are not at this present moment fit for having a surgery. We also do a physical examination. As Dr. Williams mentioned before, we might have to put a tube in to help you to breathe. Now, the process of putting a tube in sometimes can be a complex procedure, and it's something that only anesthetists really do, or people who are trained to manage an airway. And some people, just their general anatomy and body habitus, it makes it difficult to put that tube in. And so a part of the examination is to have a look at your airway. So we might ask you very weird questions like, can you open your mouth as wide as you can? Can you stick your tongue out? We might ask you to extend your neck so that we can feel the distance between your chin and the prominence in your neck here, so that we can have an idea of how difficult it may be to put that breathing tube in. Because as we said before, some of the medications that we give can cause you to stop breathing. So it's important that we know how to handle things as we progress. So I mentioned this before, if we find any issues, then we might need to do additional tests that might include imaging, blood studies, and these are all done to assess a level of risk and make an appropriate plan of anesthetic. So it's really important to be open and honest during this evaluation. It's a safe space with your physician, whoever that may be. And our main job is to take care of you, make sure that you're comfortable, answer any questions that you have. It's not a place of judgment. And so we don't want you to feel uncomfortable to divulge information that is pertinent to manage your care appropriately and prevent any adverse complications. Just again, to stress that it's important, when you go to your preoperative assessment, if you can't remember, at least write down any conditions that you have, anything that you're being followed up with your GP for, a list of medications, bring them in if you think that you might forget. And this all helps us to come up with a safe plan for you. Once we determine the plan, because there are a variety of ways to deliver an anesthetic, as was mentioned before, we discuss it with you and we determine what's most appropriate. So, for example, if you are going to have an elective cesarean section for whatever reason, it's good for you to be awake to see the delivery of your baby. And so we might think that, or we're probably going to advocate that a neuroaxial technique is probably what's best, because it's something that will help for the pain, for the cut after the operation is completed. And again, it helps for you to hear the baby's first cry, to have that first contact, skin to skin, right after the baby is born. And so, you know, there's some methods of anesthesia that are safer than others, depending on the conditions that you have. So if you have heart disease, a general anesthetic, depending on how severe your heart disease, might not be appropriate for you, because there are lots of other things that an anesthetic can do to the body. It can drop your blood pressure. And if your heart is already failing to pump and we drop your blood pressure, it might make this failure worse. And so maybe a technique where we just block the area that you're having the operation on is safer, because it causes a less generalized response to the anesthetic. So in our preoperative assessment, that is when, based on everything that we've heard, we'll come up with an anesthetic plan that is safe to proceed, and one that you are comfortable with as well. And then once that happens, the countdown begins. You'll be given advice before the operation. So like I said, if there's some medications that you're not meant to have before, you will be made aware that a day or two before the surgery, please stop taking this medication. And so the instructions will be quite clear to you. There are certain activities, again, that pose increased risks of complications after an anesthetic. So for example, smoking affects the lung function. And remember, for the large part, depending on the operation that you're having, we're taking over your lung function. And so it's really important that they'll give you advice for a few weeks, more likely, before the operation, for you to stop certain activities like smoking or drinking alcohol, because that can affect the efficiency with which we're able to deliver our anesthetic. And of course, we're only going to proceed once we feel that you are in the best state of health to have the best outcome, because what we don't want is adverse complications. Very important that you are going to be required not to have anything to eat or drink before the operation. And you'll be told that, you know, midnight the night before, don't have any more food. And this is because, again, a variety of things happen or change in the body when we give you an anesthetic. So, you know, if you're having something to eat and something funny happens and you bust a laugh and the tube goes down the wrong place and you start to choke, these are reflexes in our airway that help to prevent food from going into the lung and causing complications. So if you have just had a big meal right before we put you to sleep, there is a risk that the food can come up and go into the lung. That can cause severe inflammation, it can cause a severe infection, and it can even cause death. And so this is a very preventable complications just by simply not having anything to eat or drink. And it is something that if you tell us that you have had something to eat or drink, because we need to perform this safely and ensure that your health is, of utmost importance, we won't be able to do the operation because, again, you're at great risk of having a complication. Now, there are certain instances where a surgery might not be planned, and so we might not be able to do as extensive of a history examination, investigations, etc., before having it, like, for example, an appendicitis, or even if you're pregnant, you plan to have a natural delivery, but there was a complication and you now have to have an emergency cesarean section. We do a more curtailed version of what I just said. So we're still going to do a history, we're still going to do an examination, and we're still going to do routine labs, but we're not going to be able to do extensive studies as we would have before because no time is against us, because this operation needs to happen within a certain time frame. So of course, as you can imagine, if you have illnesses or things that put you at higher risk, the outcome of the operation or the risks associated with those operations are a bit higher because we're not able to do them in as controlled a setting as we would like. But at that point, your overall health comes first. And if you have to have your appendix out, you have to have your appendix out. But we still continue and go ahead with the operation in a safer way as we can. You're informed of the risks before, and it's likely that you're going to be staying in hospital so that we can monitor you and deal with any adverse complications should they arise. And this is just a picture of what it's like in the anesthetic room. So those are anesthetists. There's lots of people, there's going to be lots of people in the room. I'm going to explain their roles in a bit, but you're normally anesthetized in the anesthetic room before you head into the operating theater. So what happens on the day of your surgery? So I'll give you an example of an elective surgery because that of an elective versus an emergency surgery is different. As standard, we monitor your heart rate, your blood pressure, and your oxygen levels, no matter what surgery you're having. So when you come in for the day, the nurse will greet you. They'll do your initial observations, so your initial blood pressure, heart rate, etc. And then they'll give you the introductory talk. Then your anesthetist will come and will do a very abbreviated version of what you had in your preoperative assessment. So we're still going to ask the same questions. And this is because things might have changed between when you had your initial anesthetic evaluation and when you actually present to your surgery, because sometimes that can be weeks apart. So we'll still do an abbreviated history examination and ask you questions to make sure that it's still safe to proceed. And then, based on the operation that you're going to have, we determine, you might already have your anesthetic plan, but we'll confirm that it's still safe to do so. The monitoring that you have, aside from the basic ones that I just mentioned, also depend on what surgery you're having. So if you're just having a lump removed from your breast, it's just standard monitoring. But if you're having a more extensive operation, it might be required to do more advanced monitoring. And so the beginning or in the anesthetic room when we're preparing you, we might have to put additional lines or monitors on to make sure that we're monitoring you as safely as possible. So during the day, you're going to be asked the same questions a million times before it's time to put you to sleep, to confirm your name, your date of birth, what operation you're having, because we want to make sure that we're treating the right patient and we're performing the correct procedure for you. When you get into the anesthetic room, you'll have on a gown. We'll put on the monitors, like I mentioned. We're going to put a cannula or a drip in the arm. That's how we're going to give you the medications for the sedation to put you to sleep, medications for pain, antibiotics, fluids. And then we'll go through what we're going to do depending on the kind of anesthetic that, is going to be performed. So if you're going to be put to sleep, at that point, a mask is going to go over the face. That's just to fill the lungs up with oxygen. We can give you the medication to put you off to sleep either via that same drip or a gas. So you might start to smell a funny smell. It's usually a bit sweet before you go off to sleep. And at that point, you're not going to remember anything else that happened because we're going to now put the tube in that's going to breathe for you during the operation. And then we're going to take you into the theater for the operation to happen. So the last thing that you're really going to remember is just that process of getting the monitors on, confirming again that we have the right person, putting the drip in and just giving you some medications to put you off to sleep. Some of those medications, sometimes they burn a bit as they go through the cannula. Again, that goes away very quickly, and it's not something that you feel after the operation has happened. When we take you into the theater, we again monitor you throughout. So we monitor you with the same things that I mentioned. You monitor your blood pressure, your oxygen levels, your heart, and make sure that everything is okay. You are very closely monitored by your anesthetist the entire time. If you have a spinal or epidural and you're still awake, sometimes that can be quite an anxious thing, because you're hearing people talking, you're hearing the surgical instruments. You won't feel pain, but you can sometimes feel tugging. So you might feel pressure, not pain. And sometimes I think just the concept of knowing that somebody's doing an operation and you're feeling something is quite anxiety inducing. And so we can give you medications to help to curb that anxiety without completely putting you to sleep. So it just depends on what anesthetic that you have. I know some things that some people have mentioned before is, will I wake up during my operation? Now, again, I mentioned that we monitor you quite closely, and as anesthetists, we know how the body is supposed to work. So based on the observations, we can detect whether or not your anesthetic is lightening just based on your heart rate and your blood pressure. But there are also additional things that we can use to monitor. So we'll put some like electrodes, kind of like the same sticky things that they put to monitor your heart, but we'll put them around the head. They don't hurt. It's not an invasive thing. And it helps us to monitor the brain activity. And so by that, we can also use to more accurately determine the depth of anesthesia. That's not always indicated because it depends on the kind of anesthetic that you're giving. That's only appropriate for some anesthetics, but it's just to say that you are very closely monitored. And so even small, minute changes in what's happening in your body, we're able to pick up quite quickly. So what are you going to do after the anesthetic has been given, or what happens afterwards? So if you've had a general anesthetic, so you've been put to sleep, and Dr. Williams mentioned sometimes depending on the surgery, you might be paralyzed. So sometimes when the surgeons are operating on the gut, it requires the body to be very, very still, and they don't want the movements of breathing to interfere with what they're doing. We make sure that we reverse any medication that we give before you are conscious and aware. So if you're paralyzed, we reverse the paralysis before we even wake you up. So it's not going to be a case where you wake up and you can't move. And I know that's some things that people might worry about, because it is quite scary to hear that you're going to be paralyzed. But this is a reversible thing, and you're never going to wake up without the ability to move. So we stop everything that we're giving. If it's a gas, we turn the gas off. If it was medication going through the drip, we stop that medication and we allow you to wake up. And then we get to the point where we deem it safe, that your airway reflexes are back, like I mentioned before. So once it's safe, we'll take that breathing tube out. Sometimes your throat might feel a bit sore just because of where the tube was sat in the throat. But once you're breathing on your own, you're coughing, the anesthetist is going to ask you to give them a nice big cough just so that we make sure that, those reflexes are back. We'll take the tube out and we'll take you to recovery. During the process, you would have been already getting medications to help with pain and to prevent sickness, which are the most common things that patients will have after an operation. And we also have plans to continue that care. So plans for further medication, anti-sickness medications and painkillers to help to manage those symptoms, even in the recovery period. Now, what happens after is very dependent on the operation that you have. So if you have a simple operation, like, again, removal of a breast lump, that can be something that's done as a day case, so you can go home the same day. But if you have a more extensive operation, especially if you've had a lot of blood loss, then you might need to stay in the hospital afterwards. And there's some operations that are so extensive that you might be sent to the high dependency unit or intensive care. And that's not necessarily that something went wrong, but just because you need to be in an environment where you can be monitored a lot more closely. And so where you go after your operation is heavily dependent on the operation that you've had, but all of these will be discussed with you before the surgery, so you'll know the plan. If, of course, you're going to be sent home, it's really important that you have somebody to come and pick you up from the hospital, because, of course, if you've been giving a sedative, it's not safe for you to drive. So somebody will need to to come to the hospital to pick you up. And we also implore you to have someone to stay with you overnight. You will be giving warning signs, very dependent on the operation that you have as to what to look out for, but you'll be giving warning signs. So in case you experience any of the symptoms, that you need to seek medical attention. So it's important that you have somebody who can help to get you back to the hospital in a timely fashion, in case you have any complications. So what are the risks of having an anesthetic? Because all of what we've said, I'm sure, can be quite anxiety inducing. So the risk is determined by a lot of factors. And these are the things that we try to get out of the history we take before having an anesthetic. So your age, people who are older are more likely to have complications than people who are younger. Your pre-morbid state, which just refers to how healthy you were. So, this is heavily dependent on disease burden. So if you have chronic illnesses that are affecting normal bodily functions, that can put you at higher risk. But again, this risk is determined before the surgery, and we try to optimize as best as possible to help to minimize the occurrence of these complications. And of course, the risk is also dependent on the procedure. Some procedures are simple and have a very minimal risk of complication, while some are very complex, like operations on the brain or operations on the major vessels of the heart. So the risk is dependent on the operation that you are doing as well. But if we give figures, the overall risk of death from an anesthetic is 1 in 4 per 100,000. And the risk of awareness can be up to 1 in 20,000. And that is, in basic terms, waking up during an anesthetic. But how do we compare this to other risks? So using figures from the US National Safety Council for your lifetime odds of death, you are more likely to die in a motor vehicle crash, from a fall, from choking on food, from a dog attack, than from having an anesthetic. And so you're, in the grand scheme of things, compared to you are more likely to die from being killed in an accident at work than from having an anesthetic. So the risks are quite low, and the complications are quite well known. And so we know how to treat you to help to prevent and minimize the occurrence of those complications. The truth is that the medical profession in general, realize how essential anesthetists were to healthcare, because we don't just put you to sleep. We work in all of the acute areas. So if somebody has heart has stopped, the first person that they're going to call is an anesthetist. We work in pre-hospital care as well. So sometimes people have heart attacks outside of the hospital, and an anesthetist might be called to help to resuscitate them before they get into hospital. So our role is quite widespread throughout the hospital, not just in the operating theatre. And with the advent of specialist anesthetists, the risk of death from anesthesia has decreased dramatically over the past 200 years. So that being said, there are more common risks or adverse events which still require frequent attention. So I mentioned them before: nausea and vomiting, forgetfulness. Sometimes you might not really remember what has happened, in the time leading up to the surgery, right before. So when we put you to sleep. And like I said, sore throat from where the airway device would have been sat. But these are transient complications, side effects. They go away and they're easily treatable. And that's all we have for you.
Great, thank you so much. We'll get on to the questions lovely, perfect. Okay, thank you. It's just always, anesthesia is just one of those areas that I think, as I said earlier, that isn't really talked about a lot. And I don't even think that many people don't even know the term, as it were. So being able to digest that so beautifully for us. And I think one of the things for me is with your slides about the risks, because a lot of people talk about, oh gosh, no, I don't want to go under, what if I never wake up? What if something happens? And actually, I always say that, very similar to some of the stats that you gave, is that things that we do every day are far more riskier than anything in operation. And the things that often resulted in you having the operation are the more riskier things. The
Exactly.
operation
Definitely.
is the safest thing. So no, so it's fantastic to hear you say that. And I think also the role of the anaesthetist. Sometimes I think if you've unfortunately just had to see an anaesthetist in an emergency situation, you don't really get to even know their name because you're just in a blur. But I always say they're kind of the engine room of the hospital. So and if anything happens, you know, in acute situation, just saying it as a fellow doctor, you want an anaesthetist around. So they're very treasured in hospitals. So no, thank you so much. We've had some questions come through, but I just want to give people the opportunity that are on the line, if they want to put up their hand and ask us a question directly. If anyone would like to do that first of all, feel free. Otherwise, if you're preparing yourself to get your question to us, I'll just start off with one of the questions. So one of the questions is, if you do have high blood pressure, does this need to be reduced before you can have an operation? So just about the management of blood pressure around operations.
Yeah, so it depends on how high the blood pressure is. So, you know, there are different ranges that are associated with adverse effects. So heart attack, strokes, kidney disease. And so if your blood pressure is deemed to be high, or too high to safely proceed, then it will be optimized before you have your operation. But just having high blood pressure in and of itself, if your blood pressure is maintained by the medications that you're currently taking, that should be fine in terms of progression. But that's something that will be discussed at your preoperative assessment, and more often you'll have your observations taken. So your blood pressure will be taken, and we can assess to see how high it is and what the risks are. Do we need to address anything before it's safe to proceed? So all of this will be handled in your preoperative assessment.
Yeah, just to chime in, as Regina said, it depends, I think, more on the progression of your high blood pressure and the complications that you have, because high blood pressure tends to lead to many things, as she said. So what we look at is a function of the heart, function of the kidneys, and there are also some conditions in which high blood pressure is caused by the reason that we're doing the surgery. So you can have certain tumors in certain, like an adrenal tumor, etc., that we'd expect that you're going to have very high blood pressures, and we would have prepared our anesthetic approach in such a way that if it is that your pressures do go very high during the procedure, that we can get them down quite quickly and safely for you while still facilitating the procedure.
Thank you. No, thank you both. Those are great answers. And I think what it also just, two things reinforces is the importance of pre-assessment appointments and attending your pre-assessment appointment and being open and honest.
Having the right information at your pre-assessment appointment so that we can address all of your concerns.
Exactly, because I find that you know, within our communities we're not very good at doing that. We will voice our concerns at home and then with our friends and family, and then in front of the doctors we don't say anything. And actually there's a lot that we can do if we know to give you that support that you need. So no, thank you so much. I'll go to some of the hands and I'll go to some of the other questions. John?
Thank you so much, Dr. Vanessa, and thank you for the two doctors. This is a presentation that is insightful. My question is, it's not a question, but my concern is that I'm not sure if it is psychological, but for me, the times I've had anesthesia, I continue feeling the pain through the procedure.
Oh.
Yeah, thank you. What happens?
Were you put to sleep for your procedure, or were you still awake?
Not to sleep.
Oh, you were still not to sleep.
Yeah.
So it's possible, depending on what exactly you had done. When Dr. Williams went through the different kinds of anesthetic, if you just have anesthesia to the skin, for example, it might not block all of the pain, and so you might still feel some discomfort. If you have anesthetic at the level of the spinal cord, then that's the optimal blockage of transmission of pain, because it's right where the nerves go to the brain to say, okay, this is painful, stop it. So, you know, it depends on the kind of anesthetic that you have as to how complete the coverage is to prevent pain. So that's one thing. And another thing that I found, and Dr. Williams can say his opinion, is when you give anesthetics locally, sometimes people find it difficult to differentiate between pressure and pain. So, you know, you feel something tugging. Sometimes, you know, they'll put instruments in and they'll open things to have better access to things. And so you'll feel that stretch, but it's not painful. But in your head, you know that somebody has a knife on your skin. And so it might feel uncomfortable and it might feel like, oh my God, something is happening. And, you know, your brain might just say, it hurts. But it doesn't actually hurt, it's just pressure. And so that's why it's really important to have these conversations in our preoperative assessment, because some people just genuinely can't tolerate how that feels. And if that is the case, then maybe a general anesthetic is more appropriate, because what we don't want is for you to be anxious the whole time, because, you know, you're not sedated, your muscles are not relaxed. So if you stiffen up while something is being done, it affects how the surgeons are able to perform the operation. And God knows nobody wants you to be, you know, an anxious wreck the whole time. We want you to be calm, we want you to be relaxed. As Kristoffer said, if you have high blood pressure and you're very anxious about what's happening, your blood pressure is just going to shoot up. So, you know, these are all things that we want to get a feel for. So please, please, don't feel too scared to tell your anesthetist, doc, I am afraid. I don't know if I can manage this, because that's okay. It's not all anesthetic procedures are suitable for everyone. Some people just, you know, it's too anxious for them to have. And so if you really think, oh my God, I don't think I can manage this, or you don't want to see anything, or you don't want to hear anything, then maybe, you know, being put to sleep might be what is better for you.
Just to add to that, so it is a balance that we're trying to achieve. We're trying to at least make the procedure tolerable, but the ideal is to make it completely painless. We do find, however, that different persons have different tolerances to certain medications that we may use. So a dose of local anesthetic that I may require may be half the dose of local anesthetic that you may require. Right? And there are also certain things that will influence the amount of local anesthetic that you require as well. So for persons who may smoke, or persons who use certain classes of drugs, other medication, they may require higher doses. The balance that we have to strike is that we also have to give you a safe dose of the anesthetic. And if we go above that dose, then we invite certain complications and adverse reactions that that then make it unsafe to continue to administer the drug. As a bit of a controversial point, but I think it's something that we need to drive home, especially in a forum like this, is that there have been murmurs in the past that suggest that Black persons or persons of color are less sensitive to certain procedures, or they have quote unquote thicker skin, etc., and that they don't need as much pain medication. That's total nonsense. Right, that's rubbish. And when you're with your physician, I encourage you, if you're feeling pain, if you're feeling any type of discomfort at all, don't be afraid to say, hey, doc, listen, I'm not comfortable with this. I'm feeling pain. It is our responsibility to try to get you to a state where you can tolerate the procedure comfortably. Right?
And just to add to that about pain, it's also really important in the post-operative period that if you are feeling a lot of pain, please, I know we don't like to take medications as a community, but please say, doc, I am feeling pain, because sometimes that pain could be indicative of a complication. So there is normal pain that you'd have after operation that we need to manage. And then there's pathological pain that might mean something bad is happening. So it's really important that if you are feeling pain, don't feel shy to say, I am uncomfortable, because it's our job to make sure that you are comfortable and safe.
Thank you so much. And I just want to, I think if there are a couple of people, if anyone who's not speaking, if they could mute, that's great. I think this is such an important topic. And for the first bit of it is that, again, how you've described it is so well, is that sensation of stretching and thinking it's pain, but your mind's telling you it's pain, so you're really a lot of anxiety. And you know, I'm always open and honest in these things. I've had quite a few operations for a number of reasons, but for my C-section, you know what's happening. You can see they're stretching you, so you know. But oh gosh, and I was like, you know, holding my hand tightly and saying, you know, and I feel I'm quite a chill person, and I knew what was happening. And so, you know, it's completely natural to have those anxieties, and and not to be shy to voice them. And there's a question in the chat which relates to this, and I'll come on to the second part of what you were talking about earlier, but it was someone saying that they have an anxiety disorder, and they worry about things like this. And so how are people managed with general anxiety disorder ahead of anaesthetic? And I think you touched on some of that in terms of the supports that's given, but I don't know if you want to add anything to that. But I think, yeah, you gave some really good insights into that.
Yeah, so we do come across a lot of patients who have anxiety or depression, and, you know, just the concept of knowing that you're going to be put to sleep and you're in such a vulnerable state really is triggering for them. And so we often give pre-medication, and this is a variety of things. We will start the process of trying to prevent sickness, trying to prevent pain, trying to prevent burning of the stomach for those people who have ulcers or, you know, or reflux problems. And in that period, if you are deemed to have issues with anxiety, we start the process of giving you very low dose, almost sedatives that will help to curb the anxiety. So not enough to put you to sleep or to make you feel super drowsy, but it will be similar to the medications that you would get if you were on medications for anxiety. It just helps to curb those anxious feelings. And so we'll start with that in the preoperative phase before you even come to theater, because the minute you get the gown on and you're pushed off, that's when, you know, it gets real and people start to get afraid. And so we'll start giving you that medication, even sometimes the night before, depending on the kind of medication that we're giving you and it's, you know, how long it acts. So if this is something that, you know, you struggle with, again, please mention it at your preoperative assessment, because then we can tailor the medications and the plan so that we help with not only the physical symptoms, but the psychological symptoms of knowing that you have to have an operation. And anesthetists we're also cheerleaders, honestly. We sit by your head and we hold your hand and we rub your head and we make jokes and we try to make it as comfortable as possible. So we really do try to distract you from what's happening so that you're not fixated on, oh my God, they're cutting me, you know? So we're here to help.
Just to add to that, if I may, as it relates to anxiety as well, another thing that we do as anesthetists is for persons who require sedation for certain procedures that might be out of hospital. Not infrequently, you'll have patients who are claustrophobic or who, you know, just suffer from severe anxiety and they need to have certain procedures done. And it's often possible to get an anesthetist to go with this procedure, say for a CAT scan or an MRI. I mean, the MRI scanner can be quite imposing. You know, it's a small space, it's very loud, it tends to be very cold, etc. There's some patients who will require a little bit of medication to kind of ease their anxiety or to give them a very light sleep. For dental procedures as well, there's some patients who don't tolerate that very well. Someone poking around their mouth with these metal instruments looks very barbaric. Some people may need a little bit of help to get through those procedures. So anesthetists also work in those functions. It's not very well publicized, but it's possible and something that you could have looked into if you find that it's very difficult for you to tolerate procedures like that.
Great. No, thank you so much. And I think before I just acknowledge what you said in part of your answer of the previous question about that false perception, where it comes from, about Black skin being more pain tolerant, etc. I think it's a reality. It's a sad reality, but it is a reality, and there are many people who do not think like that, but a proportion of people that do, and I think again it's reinforcing why we also need to voice what we're experiencing, so that our lived experience and what we're going through is acknowledged, because otherwise we will get lost in someone's biases. So no, thank you for highlighting that. So a couple of questions about related to how the anesthesia is managed. So one person has said, what happens if a person doesn't know that they're allergic to any medications ahead of anesthetic or surgery, and it comes out within the surgery? I'm presuming that question means.
Yeah.
So that's a great question, actually. And to be honest, that is very possible. Unfortunately, we don't know what we're allergic to as individuals. It's something that we happen upon, or we find out just by chance by interacting with these medications. The other part of it is that anesthetic medications are usually very highly controlled medications. They're not available for use in a general practice or anywhere else, to be honest, because of how powerful they are and the effects. We really need to have very specific training before you can start administering anesthetic drugs. However, that training also includes the capability to deal with a severe allergic reaction, which we refer to as anaphylaxis. All right. So one of the first things that you're actually taught, and we do continuous training on this, is how to deal with an anaphylactic reaction, so a severe allergic reaction. Sometimes you'll give a medication and you'll notice that the patient's observations have changed, and they may get a bit rashy, etc. They may have some difficulty breathing or some chest tightness. And we have the medications on hand. They're part of our anesthetic stock. They're literally just beside us. And we're able to administer the medication in a very timely fashion, and to do tests to figure out exactly what went wrong, and to try our best to determine what medication it may have been that causes allergic reaction. And then, of course, there are other fail-safes that we have, so that if it is that you've been noted to have an allergic reaction, immediately it's put on your medical record. An alert is sent out to your general practitioner, and it becomes a part of your permanent medical health record. Another thing that we will do is, if you already have recognized allergies when you come into the hospital, you're provided with a specific wristband, which is a red wristband, which alerts all hospital staff to the fact that you do have an allergy. And so when a patient comes to us with a red wristband, we're even more on guard to say, hey, obviously this patient has an allergy of some sort. So let's have a good look at the medical notes. Let's figure out exactly what they're allergic to, and not just a specific medication that they're allergic to is the one that we'll avoid, but we'll avoid that entire family of medications if we can avoid it.
And just to add to that, if you have an allergic reaction to a medication, it kind of falls on a spectrum. So you might just have a simple rash, and we can just give you medications for that, and it might still be safe to proceed with the procedure. But sometimes you might have quite a generalized and severe allergic reaction that might affect your ability to breathe. It might affect your blood pressure. If that happens, then you might have to be, well, it's very likely that you'll be admitted to hospital after the operation to monitor you and assess the progress of that allergic reaction, and making sure that we are keeping you safe during that, inflammatory period. So, allergies are encountered quite commonly. Severe reaction is in a bit more infrequent, but because you're monitored quite closely, so we see changes in your oxygen, and the first thing that we normally see is a rash or changes in your blood pressure. And when we're very trained, as Dr. Williams said, to be alert to critical incidents that can happen, anaphylaxis being one, and then we can address it quickly.
Thank you. And I can give a personal reflection of the fact of I had so I thank you for being honest about it, the possibility of reacting to medications. And I had a reaction to anesthetic, and there is no better place that you would want to be than with your anaesthetist. And they spotted it within minutes, seconds, minutes, and dealt with it. And essentially, I would say I don't underestimate it. It saved my life. And then it's on my record. And so whenever I've had anything else, then they've revised the anesthetic to suit me. So it's again, it's important to share, to just allay people's fears and know that you're monitored and you're cared for and you're in the right place. So no, thank you. And someone has asked, is the anesthetic adjusted according to the patient's weight?
Yeah, okay. So the simple answer is yes. More so for the pediatric population, or for children, or for smaller adults. As I said, the medication that we use, it's quite powerful. And so we have to, what we call titrate, or get the effect that we want based on the amount of medication that we're giving. Obviously, we're not going to give, a tiny baby who's a newborn the same as we're going to give a grown adult. Many of the medications that we do use to induce anesthesia are the same, but we use different amounts, or we may use a different combination. Generally speaking, though, what we are guided by the amount of medication that we use, meaning that we know what the safe range of medication is. And within that safe range, we give the medication to the effect that we want to achieve. So we may know that, giving 2 syringes of a particular medication is safe. You as a patient may only require half a syringe. So if we're happy with where you are after getting half a syringe of the medication, then we don't need to give you anymore. If it is that after, we've looked at it and we say, this person probably is going to need 1 syringe, but we know that you can go up to 2. We've given you 1 syringe and you're still awake and looking at us and laughing. We may say, hey, let's give the other syringe to ensure that this person goes off to sleep. And similarly with local anesthetics, as I was saying to John earlier, we do have a safe range in which we work. And we know that we may need to top up. And of course, we make every effort to not go to the highest range, because then we know that the amount that we have to play with is much smaller, and the potential for an adverse effect based on an overdose is much greater the closer we go to the higher limit, to the higher part of the limit.
And so just to add, when you do your preoperative assessment, again, back to the preoperative assessment, your weight and height will be checked by whoever sees you, because as Dr. Williams says, even though we have a safe range, the range is based on weight. So the dose that it would take to put me off to sleep will be different from what it takes to put him off to sleep. And so your weight will be checked before you have the operation. And in emergency cases, we can't check your weight. We don't just always have scales lying about, but we do an approximation based on what you would appear to weigh.
Great, thank you, fantastic. Landy, you have your hand up.
Thank you, Dr. Vanessa. Thank you, doctors, for this very enlightening session. And to you too, Dr. Vanessa, for sharing some of your personal experiences. For me, I had an epidural with my first child. And what happened was that one side, it worked on one side, and then I continued to feel, some pain on the other side. So I've always been curious as to what happened, if you could provide some insights on that.
Yeah, that's fun.
Yeah, so sometimes, we didn't quite touch on it, but so you can get a spinal and an epidural. Sometimes it fails, and sometimes it's patchy, the pain relief that you do feel. So it might cover some of the nerves, but maybe not all of them. And so, it's something that you can't quite predict. There is a certain amount of medication that we give to help to, prevent pain that for all of the nerves, but that doesn't always happen. And it's difficult to say why. We don't quite know why, but that is something that, we always say, if we're going to offer you a spinal or an epidural or, a neuroaxial anesthetic, that there's a risk that it might fail and we might have to convert to a general anesthetic. So that can happen. And, sometimes the pain control or, your ability to perceive pain is not quite at the level that we'd expect. So before we proceed, if we've given you a spinal or an epidural, we do tests. So we touch you, we have sprays that can, and we ask you to see if you can detect temperature. So we do some tests before, we start cutting. So it's not like we'll do the epidural and then it's time to have the procedure and you'll be in pain. We'll test it first so that we know that it's safe to proceed. And if it isn't, then we'll have a discussion as to whether or not we now need to convert to a general anesthetic. And I'm really sorry that you went through that, because I can imagine that might, you're delivering your baby and you're feeling uncomfortable. I'm sorry that happened to you.
Thank you, doctor. Maybe I should also clarify that I did have a mobile epidural, so I don't know if what was going on.
You still shouldn't feel pain, so it might just have meant that you had a patchy block, which is unfortunate,
but not infrequent.
Yeah, it is one of the known complications, which is why it's tested before.
Thank you.
Thank you. And it's always as ever, there's thick and fast questions coming through, and I'm very aware that I need to hand over very, very soon. But I've got 2 questions, and then I think then we'll have to hand over. The first question is, can an epidural give you long-term backache? And this is something that I think is always one of those things that everyone always shares. Oh yeah, I'm sure it does. So yes, please do enlighten us.
So you can, when we do these procedures, they're done in a particular way. So we, like we said, we're trained so that we know the physiology and anatomy. So we know where we're going and where we're introducing sharp things that can cause damage. But one of the known complications is that you can inadvertently hit a nerve, which can cause complications afterwards. Now, these complications are very rare. One of the things that people always worry about is, if I have a spinal, will I be paralyzed? The rate of that happening is like 0.1 to 0.2%. It's a very, very rare complication. But in our training, we're taught to do these things, but we're taught about all the adverse effects and the things that can happen. And so just a part of, your anesthetic journey with us is not only delivering the anesthetic, but monitoring you afterwards. And so we can pick up if there are any complications or if you're feeling any discomfort that is out of the ordinary. And we can do, the follow-up investigations to assess the degree of whatever complication you may have had. But to stress, it's a very rare complication, and epidurals have become a staple in delivering, your child. It really helps to make the process of delivery a much more comfortable one. So it's not something that I would say don't have it, because it has such a very low chance of happening, and it's something that can be dealt with, and it's very unlikely that even if you have some back pain afterwards, it's very unlikely that will progress to long-term back pain.
Just to add to that, I think it's a matter of communication. So ideally, before any procedure, whoever is doing the procedure with you should brief you as to what the expectations are and what the possible complications are. And with an epidural or a spinal, that's one of the things that really should be discussed. And on the other side of things is, to be honest, we do advocate for these procedures quite heavily, because we find that they're very advantageous, not only for the procedure, but afterwards for the pain. It covers the pain very well. It reduces the amount of medication that you may need to take otherwise, which also has potential adverse effects. And largely, especially for things like labor, delivery and surgeries on the lower limbs, to have an epidural or a spinal is much safer than to be put to sleep, which I don't think is something that is really stressed. But the chances of you dying or doing poorly from an, or being left with any lasting disability from an epidural or a spinal anesthetic are far, far lower than the chances of you having a complication from a general anesthetic. There's just a lot more to do. There's a lot more medication that we use, a lot more potential for allergic reactions, a lot more potential for other complications by being put to sleep. So it's really something that we do advocate for, and we try to have our patients consider.
Thank you so much. That has been such a fantastic morning. So I just really, really want to thank you both. You were all both so eloquent in explaining a topic that we don't know much about, but also allaying fears for people, and just giving people clarification. And the last point I was going to make, and just to hand over, is that one of the listeners has commented that you know, they may have missed it, and I think they missed some of your discussions about managing anxiety during anesthesia, but wanted to know if there was any preparation before anesthesia to make them as physically and mentally prepared as possible. And so I'm going to leave you guys to end on responding to that, but before that, I just really wanted to thank you for your time today. It's been fantastic, and I just wanted to thank the audience for their participation, because as always, it's been great, and just makes the just the whole experience really, really positive and impactful. So thank you. So over to you guys just for that last reflection about preparing physically and mentally, and then I'll hand over to Elizabeth.
Yes. So it's, again, you know, as you can see, I'm a strong advocate for preoperative assessment, but that's when, you know, it's so important. I cannot stress enough for you to relay any concerns that you have. Don't think that it's something insignificant or small. If it's something that's bothering you, please say, because more often than not, it's something that we can do something about. We want to make the journey from start to finish something that is pain-free, stress-free, because you're already worrying about the operation that you're having. Nobody wants to be also worrying about it on other things. So, you know, we're trying to relieve all of these unnecessary worries. So, you know, if you do struggle with anxiety, there are medications that we can prescribe that you can take up to the night before, because some medications are more long-acting than others. And then we can give you medications, you know, right before, in the anesthetic room, right before we do anything, just to mellow you out and, you know, be stress-free before the operation. You know, depending on how severe the anxiety is, like I said, we might have to have a discussion about general anesthetic versus a regional or a spinal anesthetic, something where you'll still be awake for. If it's something that you can tolerate, then we can give you light doses of sedation throughout, so you're not asleep, but you might fall asleep, but you won't be asleep where if I touch you, you won't wake up, kind of thing. So that is something that we can consider. So that's why it's really important to bring it up so that we can make an appropriate plan to address it before the day.
Great. Thank you so much to you both. So appreciate your time here. And sorry, did you want to say something, Chris? Sorry.
Oh,
yeah. I mean, I just want to say in closing, is that where we are? No.
There was one question that we've just flagged that we wanted to address. It's about someone who had a very unfortunate experience with their child, where a tube was incorrectly placed and that child passed. And I'm so sorry for your loss. I'm so sorry that that happened to you. Unfortunately, these are things that can happen, but again, to stress how closely monitored you are, one of the common, well, not common, but from an anesthetic point of view, something that can happen is when we put that breathing tube in, sometimes that can go in the wrong place, namely the stomach. If it's in the stomach, it's not ventilating the lungs. Now, we are trained, and you know, there's been a new initiative surrounding this recently because of an event that happened, about how important it is to recognize the correct placement of the tube. And so it's something that's even more stressed now than it was before. From an anesthetic point of view, that's, you know, probably the most disastrous thing that can happen, because of course you're not breathing, and if you're not breathing, you're not getting enough oxygen, and your body doesn't get the oxygen that it needs to function, and of course you can unfortunately die. But it's something that, you know, it's like being hammered over our heads now because of incidents that have happened. So it's something that, you know, we have a thing about, you know, if there's no trace, then, you know, we have to assume that it's not where it is and take it out and start again. We have escalation plans. We have a whole algorithm in place for putting tubes in, which is why we've said that this is something that an anesthetist does, because it's something that you have to be highly trained to do, not only to perform it, but to be able to recognize that things are not going well or that things have gone wrong and address them in a timely fashion. And so, you know, I'm so sorry that that happened. And, you know, it obviously wasn't addressed, or, you know, things escalated when it was too late. And you know, my heart goes out to you and your family.
I just add to that, I'm also so sorry to hear that truly is catastrophic. And I can't imagine what that was like to have to deal with. What I can say is that in the developed world, so I know in the UK and I think in the United States as well, this is something that should, that protocols and fail-safes have been put in place so that something like this should never happen. Especially here as anesthetists in training, or as junior anesthetists, we're always covered by a consultant anesthetist and other persons who are in the operating theater who are also trained to recognize issues. So it's not something that is done lightly. It's not something that we take for granted. We do recognize that there is a risk involved, and there are many, many fail-safes in place currently, so that should anything happen, it theoretically should be recognized very promptly, and we have the facilities to address that very promptly as well. But it does remain an unfortunate complication and something that should be highlighted and discussed prior to having surgery.
Thank you both. And I also want to just acknowledge the person who talked about their loss, truly devastating. And I just want to thank you for Chris and Regina for acknowledging it and just highlighting it, because it's nothing worse than that person going home and thinking they should have asked that question and didn't have the opportunity. So thank you so much. And I think the way that you've tied everything together and just acknowledged what's happened to that person is just really reflective of how you've taken the whole session to just educate us and to give us reassurance, but also honesty as well. So thank you again, and we'll hope to see you on again. And now I am going to hand over to Elizabeth. Apologies for my hosting, just slightly a few minutes over, but really important discussion. So, but thank you, and over to Elizabeth.
Thank you so much again, Dr. Vanessa, and thank you again, Dr. Regina and Dr. Kristoffer. And no, we just again want to acknowledge for those that have just shared, I think this is what we've intended for CATHIP to be about, for people to share those lived experiences and to just feel free that this platform is for us to learn from one another. So thank you again for feeling free to share that with us. So we'd like to thank you again, Dr. Vanessa, great host as always. We love having you every week. And again, to our special guests, Dr. Regina and Dr. Kristoffer, we've loved having you on. I would hope to have you on in our future CATHIP sessions. So thank you again for honoring our invitation this morning. We also want to thank all of those that are joined in on Zoom, on Facebook and on YouTube every week, tuning in and really partaking into the session. We'd really want to appreciate you as well. And we also want to appreciate our CATHIP partners, BAHI Leeds, RAFA International, Croydon BME, Enfield Caribbean Association, and RCC Sheffield. Again, we couldn't do this without yourselves. So thank you so much again for being involved and being a part of this. Again, for today's session, we've recorded this session. It's on our Facebook page and on our YouTube channel. So please feel free to share the links with your family, your friends, your colleagues, so that they can learn from what we've also learned here this morning as well. So you can always go back to our Facebook page and our YouTube channel to see previous health hours, but also to see this week's as well. We also want to encourage those, if you have any questions, I can see on our screen, we have our survey, our polls in the chat box. We want to hear from you. How are you finding these CATHIP Health Hour sessions? Where are you tuning in from? What's the feedback? We want to hear from you, just so that we can keep that your feedback in the future health hour sessions as well. So what topics have you found very engaging, very useful? What topics would you like to hear of in the upcoming weeks? Where are you tuning in from? Please, we would love for you if you can complete the Zoom poll if you're tuning on Zoom, or if you're also on Facebook and YouTube as well. We have a survey link that's been circulated. Please do feel free to add your feedback on there. We're back again next week, as you can see on our screen here. We're back again next week, same time, same place. But next week, Thursday, we'll also be doing another CATHIP session, which will all be around depression and common causes by Dr. Omar Damola Damola, sorry, Shogade, that will be next week. So if you'd love to register, you can register ahead of time now. Feel free to email us at events@CAHN.org.uk. And you know, we're all here to help as well. So throughout the week, we have our counselling services that are here as well. So feel free to access any of these services. Our Healthy Hearts, we have our Healthy Hearts program that is all around nutrition, what we're eating, looking after our diet, healthy lifestyle. And we're back again next week, Tuesday. And next week, Tuesday is a really interesting session. We'll be having a panel discussion. So please do tune in. So that's after bank holiday. So you would have really relaxed and you would have been back and refreshed. So that's next week, Tuesday, the 30th of August. And that's from 6 p.m. to 7:30. So please get registered. You can register from today and we will send you those details, and do let your family and friends know. And next week, Tuesday, is all about cultural lifestyle and health outcomes, and it's all around research as well. So we have some of our guest speakers that will be inputting some of that in there as well. Yeah, next slide, Sven.
Thanks for a wonderful morning.
Thanks for the feedback. So again, throughout the week, there's different events, different activities going on, as my colleague is sharing on the screen there. So do feel free to just jot those down, and the contact details are on there on how you can register and how you can get involved as well. Throughout the week, again, if you need any support, our counselling service is accessible as well, where our counsellors are on the call. We have our helpline as well that you can feel free to engage with as well. If you have any questions as well, or you need access to today's slides, feel free to email us at health@CAHN.org.uk as well, and we can share that as a resource to yourselves as well. Next slide, please. Black History Month is coming up, and we're really excited as we're going to celebrate this year together in Manchester Cathedral here in Manchester. But we'll also be hopefully live streaming as well. So if you can't come down, we'll also hopefully partake this, screen this event for everyone to get involved. So do jot down all of these different events, and let's see how we can engage together as a community as well. You can move that on, and my colleague has put the contact details here in the chat box. And CAHN this year will be turning 5 years old, our anniversary. We will be having that on Saturday the 22nd of October, and we will be having different entertainment, a night of glam, elegance, and we'll be using this opportunity to do some fundraising as well. So loads of prizes up for grabs, and celebrating different members in our community as well. So do come on down, do try to get those tickets ahead of time. I believe they're selling out really quick, so we love to see different faces in the community, and you can feel free to invite your family, friends, colleagues as well, and we'd love to see you there as well. Again, like I mentioned earlier on, our counselling service is available. We have a family advocacy support service as well. So feel free to put these contact details down. If you need that extra support, we are here to support you, and our helpline is available as well.
Good afternoon, all.
So again, we just want to acknowledge all of our partners.
I'm sorry that
CATHIP, sorry. Yeah, sorry, if we can just keep ourselves on mute there. So like I mentioned, we really want to say a huge thank you to our partners and to acknowledge them. So that's Croydon BME, Net Forum, Enfield Caribbean Association, RCCG Sheffield, BHI Leeds, Rafa International. Again, all of them, we have their contact details here on the screen. If you can just flick through those, please. We have their contact details on the screen. So please do, if you're in those different areas, please do feel free to connect with those organizations as well. If you need any extra support, I believe they're there as well to support you. So feel free to connect with those organizations. Again, we'd love to see you all next week, same time, same place. And we hope you all have a lovely and enjoyable bank holiday weekend. Bye for now.